Welcome to Academy of Ultrasound's Echo232. My name is John Sheldon, and we're going to be covering week one's information this week, dealing with pericardial diseases, specifically cardiac tamponade, and this information is in your Feigenbaum textbook. So let's get right into it. Cardiac tamponade. What it is an accumulation of pericardial fluid resulting in a predictable hemodynamic alteration. Respiratory variation in the interpericardial pressure results in linked variation in filling of the right and left ventricles. That's the key to knowing if you've got cardiac tamponade. There's a couple of signs that we'll talk about in just a few minutes, one of which is respiratory variation in your inflow, that would be your mitral and your tricuspid flow. So with inspiration, intrathoracic and interpericardial pressure decreases. It augments the flow into the right heart and reduces flow out of the pulmonary veins. Results in augmented right ventricular filling and stroke volume. Also a compensatory decrease in left ventricular stroke volume in early inspiration. In expiration, interthoracic pressure and interpericardial pressure increase, with a mild decrease in right ventricular diastolic filling and a subsequent increase in left ventricular filling. So, with inspiration, you have augmented right ventricular filling. With expiration, you have a decrease in right ventricular filling for the tricuspid valve. With inspiration on the mitral valve, you have a decrease in left stroke volume. And with expiration on the mitral valve, you have an increase in left ventricular filling. So the right side goes up with inspiration, down with expiration. The left side goes down with inspiration and up with expiration. And it's a cyclic variation with the respiratory cycle. It's sufficient to create mild changes in stroke volume and blood pressure with that respiratory cycle. Let's go down here to figure 9-20. So with inspiration, you have the normal. And with tamponade, you'll notice that the right side is slightly larger with inspiration, slightly smaller with expiration. The left side with inspiration is smaller, and with expiration is larger. Typically, normal respiratory variation, no more than 10 millimeters of mercury, decrease in systolic and systemic arterial systolic pressure with inspiration. But with the accumulation of pericardial fluid, intrapericardial pressure increases the overall effect. It limits the blood volume allowable within the four cardiac chambers and exaggerates the respiration-dependent ventricular volume interaction. We're talking about cardiac tamponade from pericardial effusion. With elevation of intrapericardial pressure above normal pressure, the diastolic pressure in all four cardiac chambers becomes equalized, determined by interpericardial pressure. That's the hemodynamic hallmark of cardiac tamponade, respiratory variation. Remember, respiratory variation is the hemodynamic effect of cardiac tamponade, respiratory variation. The left ventricle has a stiffer wall and is relatively unaffected compared with the right ventricle. The result of increased interpericardial pressure and the limitation on overall cardiac volume, any interaction between the right and left ventricle becomes exaggerated. It outlines the mechanism for pulsus paradoxus. Pulsus paradoxus is where your pulses vary. Inspiration results in a disproportionate greater filling of the right ventricle and a disproportionately greater compromise of left ventricle. Again, inspiration. Expiration, the process is reversed and right ventricular filling is impeded. Left ventricular is augmented. It results in a marked exaggeration in the phasic changes in the right and left ventricular stroke volume. A substantially greater decrease in systolic arterial blood pressure with inspiration. This is the mechanism of patholic pulsus paradoxus as is seen in cardiac tamponade. Again, your systolic arterial blood pressure, there's a big change with respiration. All right, so let's go to table 9-2. In tamponade, you're going to have pericardial effusion. You may have thickening and stranding. You want to use 2D echo and M mode. You're looking for right diastolic right ventricular collapse, right atrial collapse. With Doppler, we want to look for exaggerated respiratory variation in inflow velocities, phasic variation in right ventricular outflow tract, left ventricular outflow tract, an exaggerated respiratory variation in the inferior vena cava flow. You need to understand cardiac tamponade is a clinical diagnosis. All we're doing is giving signs. We're giving echocardiographic signs or findings that lead the physician to think that there's cardiac tamponade. But it is a clinical diagnosis. We do not diagnose cardiac tamponade. Echocardiographic findings may suggest a hemodynamic abnormality. They do not establish the diagnosis of cardiac tamponade alone. Early signs of cardiac tamponade are evidence of a swinging heart. We talked about that in the last video, figure 9-10, when you have so much effusion that the heart's swinging around. It's simply a marker of a large pericardial effusion in which the four chambers are free to float within the space in a phasic manner. More specific signs of hemodynamic compromise: diastolic right ventricular outflow collapse and exaggerated right atrial collapse during atrial systole. You have diastolic right ventricular collapse. When the right ventricle should be filling, you have collapse. Description of diastolic right ventricular collapse versus via M-mode echo. Characteristic posterior motion of the anterior right ventricular wall was noted in diastole, figure 9-21. Let's go over there and take a look real quick at what a diastolic collapse using M-mode of the right ventricle would look like. Okay, so 9-21, you're actually looking at an M mode, and what we're trying to look for is diastolic collapse of the right ventricle. So you're actually seeing the right ventricle wall here. This is diastole based on the EKG at the top, systole, diastole. You're actually seeing this diastolic collapse where it just pops right down there, this little bubble or a little bump. You can actually tell with M mode that it's collapsing. You can see it in 2D also, but M mode again verifies, gives you one more finding to show the doctor. Anatomically, the right ventricular outflow tract is the more compressible area of the right ventricle. In early diastole, the left ventricular outflow tract will paradoxically collapse inward. Let's take a look at 9-22 and 9-23. You see up here in this little vision, you've got an effusion. and you've got a little bit of collapse. See this collapse right up here? You're in diastole based on your EKG, and you've got bowing down or collapse of the ventricle. It's best appreciated in the peristernal long or short axis. When the collapse extends to the body of the right ventricle, evidence that intrapericardial pressure is elevated more substantially is there. Exaggerated right atrial collapse can also be seen as a correlation of this. Let's go down here to 9-24, and we can show you right atrial collapse. Again, here's 923. This is more ventricular collapse. Again, this is your right outflow tract where the arrow is, pulmonic valve, and that shows you right ventricular collapse during diastole. (924), you've got your atrial collapse. This shows you that during diastole, atrial collapse during atrial, right down in here, this is your atrial collapse. Shouldn't do that. Occurs with timing opposite that of right ventricular collapse. So it would be in systole on the EKG, if you'll notice down here, systole on the EKG. Identifiable on two-dimensional echo from both the subcostal or apical four-chamber view. Right atrial collapse occurs immediately after normal atrial systolic contraction. Will remain collapsed throughout atrial diastole. So you got filling problems because of the pressure. In situations where a localized effusion is resulting in hemodynamic compromise, the sonographer may encounter isolated compression, usually diastolic, of the left atrium or left ventricle. So your Doppler findings in tamponade, variations again in the phasic inflow into the ventricles, right and left ventricular outflow and stroke volume can be shown. Used to evaluate mitral or tricuspid inflow or aortic or pulmonic outflow with exaggerated phasic variation needs to be documented. Under normal circumstances, peak velocity of mitral inflow varies by 15% or more, with respiration and tricuspid inflow by 5% or more. Variations in peak velocity and time velocity integral of aortic and pulmonic flow profiles typically are less than 10%. So if you have a Doppler running and you're taking aortic outflow, it shouldn't vary with respiration more than 10%. In the presence of a hemodynamically significant pericardial effusion, respiratory variation in filling is exaggerated above these thresholds, and respiratory variation in outflow tract velocities and time velocity integrals, or VTI, is likewise exaggerated. So let's go down here to 925 and take a real close look at some Doppler. So this is 925. You'll notice that with inspiration, you actually have the variation that we're talking about, and it gives you an idea. These tracks basically should come straight across the same velocity all the time. Appears that, best I can tell, we're looking at tricuspid in this top view, looking at mitral in the bottom view. So in tricuspid, you have lower velocities with expiration, higher velocities with inspiration. You put a caliper on the lowest velocity, a caliper on the highest velocity, and the difference between the two gives you your percentage of respiratory variation. Bear with me a second, I'll get you back to those figures. This is a new process for us, so hopefully it's beneficial to the student and helpful, but there are a few little glitches with making everything look perfect and professional. We're using the highlighter and the spotlight to try to make it a little clearer what I'm speaking of. So with mitral valve, you've got a decrease with inspiration and increase with expiration. So again, they're opposite. Expiration, inspiration, inspiration, expiration. They're opposite for the two valves, but again, you can substantially tell there's a large variation between the smallest flow and the largest flow after the respiration is taken into consideration. Pulse Doppler imaging of the supravena cable and hepatic vein flows also reflects abnormal filling patterns. If you can get the Doppler inflow variation as well as right ventricular diastolic collapse with M mode and or 2D, most labs, I don't know of a lab that goes to the extent of looking at SVC and those type of flows. But you do need to be aware that venal cable flow occurs in both systole and diastole almost continuously, but with the presence of interpericardial pressure increases, flow during diastole is truncated. Hepatic vein flow also reflects exaggerated respiratory phase dependency of right ventricular filling. You'll hear a cardiologist referred to the hepatic flow was blunted, meaning that the pressure is keeping it from flowing like it normally should. Let's go down here and take a look at figure 9-27. This is the hepatic flow that you have with respiratory variation, and you see how it's blunted during expiration as opposed to inspiration. Typically, the earliest feature to be noted is an exaggeration in mitral inflow patterns. Subsequent exaggeration in mitral inflow patterns will be noted. Abnormal right atrial collapse occurs at lower level of pressure elevation than does ventricular outflow tract collapse. So you're getting a hierarchy of bad to worse, so to speak. Right ventricular free wall collapse is seen only later in the development of elevated pressures. With milder elevations, right ventricular diastolic collapse may be seen in expiration but not in inspiration when right ventricular filling is augmented. Best documented with M-mode echo. Let's go down to 928 and show you that. Again, this little area right here, you have diastolic collapse of the right ventricular wall. When the pressure consistently exceeds the intravascular pressures, all these findings will be present simultaneously. In several instances, changes may not be seen, most probably the patient with significant right ventricular hypertrophy. So if you have really, really bad RVH or thickened RV walls, you may not see some of these changes. Thickening of the ventricular wall due to malignancy, cancer, overlying inflammatory response, or an overlying thrombus in hemorrhagic pericarditis. Low pressure tamponade, as may be seen in hypovolemic patients. Okay, so that deals with our section on tamponade. That ends our session tonight, or this afternoon, evening, depending on your time zone. Please go to Google, search for pericardial effusion and cardiac tamponade. You'll find plenty of videos, images. The more that you can see, the better off you'll be when you get ready to hit your clinical site. If you find any, as always, please send me a link. I'll be glad to take a look at them and see if I can give you some feedback on what you're looking at and try to give you some input, some information or some input to better understand the process. Tonight, or this time, we talked about pericardial effusions and cardiac tamponade and what you're looking for. As always, please continue your study and send me an email if you have any questions concerning this video or concerning this material, and I look forward to seeing you or talking to you in the future.